I'm Ali Razai, a functional neurosurgeon and the executive director of the WVU Rockefeller Neuroscience Institute in Morgantown, West Virginia. I'm presenting an overview of the chapter number 122 on the surgery for obsessive compulsive disorder in the 8th edition of Yeoman's and Wynn Neurological Surgery on behalf of my colleagues and co-authors Dr. Manish Ranjan, Dr. Cletus Shayo, and Dr. Zayan Zibli. The readers are encouraged to review details in the chapter further, and this PowerPoint is only a presentation as a primer and a brief overview of what is discussed and presented in more detail in the chapter. The reference numbers listed in this PowerPoint presentation are the same as it appears in the chapter. So the title is Surgery for Obsessive Compulsive Disorder, and OCD is a common condition, neuropsychiatric condition, and is a chronic and debilitating disorder that affects 2 to 3% of the population. OCD is a key example of a group of obsessive compulsive related disorders, which are now classified together in the Diagnostic and Statistical Manual on Mental Disorders, the DSM-5. OCD is a heterogeneous disease and phenotype, and it needs to be carefully diagnosed and understood by experts. Evaluations also include subjective elements, so it's not as easy to monitor as it is for tremor, which is more of a objective assessment, the motor function. OCD is ranked 10th among the leading causes of disability worldwide, and 10 to 25% of patients remain refractory or intractable despite the best available pharmacotherapy and cognitive behavioral therapy, or CBT, thus leading to significant morbidity and, as a result, are potential candidates for surgery. With regards to neurosurgical interventions, this is considered for those with moderate to severe disabling treatment refractory who have had good trials of medications and cognitive behavioral therapy and are still having significant quality of life and functionality issues. The corticostratothalamic, thalamocortical, the CSTS circuitry dysfunction is largely implicated in the pathophysiology of OCD, and the numerous node and dyscircuitry have been the targets of intervention that have been used over the past decades. It's also important to note that severe disabling OCD patients need to be evaluated by a multidisciplinary team that consists of psychiatrists, psychologists, functional neurosurgeon, and other team members working together to manage these very complex patients. The general inclusion and exclusion criteria, they're more discussed in detail, but again, treatment refractory OCD, they must have had at least 3 adequate trials of SSRIs and must have had adequate cognitive behavioral therapy and disease duration of at least 5 years with significant worsening of functional impairments and global assessment of functioning. Contraindications are standard to surgery or ablation with other stereotactic procedures, as well as having those with bipolar mood disorders or other concurrent severe psychosocial morbidities, BDD, body dysmorphic disorders, or severe personality disorders. In this algorithm, you can see once the diagnosis is confirmed and they've failed medications and cognitive behavioral therapy, the patients meet a potential criteria for surgery, and at this point, they're assessed by a multidisciplinary team. And if they're deemed a surgical candidate, they can be undergoing DBS surgery or ablative surgery, depending on the experience of the center and the team and the patient preferences or logistics, and undergo with lesioning, RF lesioning, gamma knife lesioning, or other investigational approaches such as focused ultrasound lesioning. Key considerations for neurosurgical treatment of OCD is proper selection of patients, extremely critical, needs to be done by a team of experts and management by an expert psychiatrist who's an OCD expert. They must not have significant comorbid psychiatric or personality disorders, and really needs to be assessed very carefully, and the patient and the family and the caretaker support team must be compliant or have existing evidence of compliance for the patient and the family with the care plan and follow-up. The functional neurosurgeon must have expertise in DBS or stereotactic brain surgery and lesioning to be able to do these surgeries. And surgery, again, is only an adjunct to medications and cognitive behavioral therapy, and should be not done by itself as the definitive treatment. Surgical targets for OCD includes DBS targets, and these have been the ventral anterior limb of the internal capsule and ventral striatum. That's the most common target with DBS surgery. Also, anterior limb of the internal capsule, the nucleus accumbens, inferior thalamic peduncle, and the subthalamic nucleus have been targets published for treatments of OCD. Lesioning targets include the anterior internal capsule, a capsulotomy, cingulotomy, subchondral tractotomy, and limbic leucotomy. With respect to DBS targets, the most common target for OCD is the ventral capsule, ventral striatum, nucleus accumbens. This is the FDA-approved targets in the United States. And this region that has the DBS implanted has connectivity to networks in the brain involved with emotional regulation, behavioral control, anxiety, compulsivity, and attention and disinhibition and inhibitory control decision-making. And this is the most common target. You can see in this ventral section, the shaft of the internal capsule, and you can see the nucleus accumbens ventrally and the ventral striatum, and the DBS lead goes down the shaft of the capsule with DBS contacts being in the ventral capsule and the ventral striatum. The nucleus accumbens has multiple divisions, a fairly large structure, but essentially the target involves the ventral anterior internal capsule and the accumbens, which has a shell and the core components of the nucleus accumbens that can be modulated with DBS. So with regards to DBS for OCD, targets most common are the ventral capsule, ventral striatum, nucleus accumbens, subthalamic nucleus, inferior thalamic peduncle, and ventral capsule. More than 300 patients reported in the literature. Roughly global response rate, which is 25 to 30%, 35% improvement in the Yale-Brown Obsessive Compulsive score, has been about 60%, and you've demonstrated improvements in anxiety, obsessions, and compulsions, and safety. The Food and Drug Administration in the U.S. has approved DBS for OCD, and this is the FDA use of DBS in the treatment of OCD under a humanitarian device exemption, or HDE, and the approval was based on clinical experience with safety and efficacy from literature, and specifically one important study looking at 26 patients with severe treatment-resistant OCD who were treated with DBS at Leuven, Antwerp, Butler Hospital. Our team, when I was at Cleveland Clinic and University of Florida, demonstrating progressive improvements in the Yale-Brown Obsessive Compulsive score and global assessment of functioning and safety in this cohort. And so the Medtronic system is FDA approved. The Medtronic Reclaim DBS therapy is indicated for bilateral stimulation of the anterior limb of the internal capsule as an adjunct to medications and as an alternative to anterior capsulotomy, lesioning for treatment of chronic severe treatment-resistant OCD in adult patients who have failed at least 3 selective serotonin reuptake inhibitors. The responder rates for OCD and neurosurgery are roughly defined as more than 35%. If you have improvements of more than 35% in Yale-Brown Obsessive Compulsive score, or YBOX, and that means a 35% reduction, you're considered a responder to treatment. And in properly selected patients that meet the criteria, DBS can be safe and effective treatment in alleviating OCD symptoms with an approximately 35 to 45% reduction in YBOX scores and overall 40 to 60% responder rate in the cohorts. DBS has the general advantage of being adjustable over time with OCD symptom variations, and but it requires an implant and the adverse effects and the cost associated with it, and complications of infections and heart rate-related issues, and lifelong maintenance. So it depends on the center and the neurosurgeon, the team's expertise and preference, and patient-related considerations. So again, with respect to options and outcomes, ablative surgery such as radiofrequency, lesioning, cingulotomy, capsulotomy, subchondral tractotomy, and limbic leucotomy can be safe and effective in experienced centers. Lesioning is destructive and permanent, however, so expert neurosurgeons need to do this who have experience with lesioning. Gamma knife radiosurgery capsulotomy offers another ablative alternative without requirements for open surgery, and it has a risk of radiation. And recently, studies have shown that MR-guided focused ultrasound capsulotomy is being investigated as a transcranial incisionless ablative procedure without surgical hardware risks or risks of radiation, but this is still being investigated. Looking at the pool results of surgery for OCD, both are effective, and in some studies show that ablative surgeries can have better efficacy as compared to DBS, but again, this needs to be further compared in a randomized trial. But effectively, both ablative and DBS surgery can be effective and safe in the hands of very experienced teams with DBS and ablative procedures. And there's broadly a global percentage of white box reduction in DBS with estimated 45% responder rates, 45% reduction, and global responder rate of 60%. And again, white box improvements and global functional states have improved. DBS is more common than ablative procedures for OCD worldwide. Again, depends on experience and what the teams are comfortable with. And DBS is more common because there's been a much larger experience of DBS for movement disorders that's now translated into centers and surgeons now with DBS for OCD in multidisciplinary centers. DBS is perceived more acceptable by clinicians and patients roughly, and DBS is non-destructive and adjustable over time, so it allows you to modulate the DBS settings as the disease and the clinical status progresses. So neurosurgical treatments for OCD, in summary, both DBS and ablative procedures, including radiofrequency and radiosurgery, are effective treatment options for severe intractable OCD, and this requires experienced teams. However, we need more research, longer-term outcomes, and randomized controlled trial studies that are done to really get a better understanding of the role of neurosurgery for OCD. And it's important to understand that surgery is only an adjunct to the best-in-practice medications and cognitive behavioral therapy, and it needs to be done as part of a larger multidisciplinary team that includes expert psychiatrists and psychologists. The neurosurgeon cannot be the primary individual managing these patients. Neurosurgeon is an adjunct procedure, and the primary management of these patients is done by psychiatrists and psychologists. And the best intervention should be individualized based on the patient's and related factors and preferences, and the neurosurgeon team's experience with lesioning or DBS and other aspects of treatment. But essentially, those that are severe treatment-resistant OCD can be benefiting by neurosurgical procedure at this time, and more studies are needed with this longer-term outcomes and controlled trials in the future. Thank you very much for your attention, and you can refer to more details in the chapter about the neurosurgical treatments for OCD.